Hi, everyone. I'm Ashley Bassett,
And I'm Catherine Logan.
and welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopaedic Society for Sports Medicine annual meeting in Denver, Colorado.
The AAOS meeting is a premier sports meeting conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lectures. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 8 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. From the sidelines to the OR, orthopedic surgeons like Dr. Kevin Farmer are used to treating shoulder injuries in both D1 and pro athletes, and weekend warriors alike.
The Arthrex Knotless 1.8 Fiber Tack Soft Anchor is the latest in knotless tensionable technology for shoulder instability, allowing the ultimate adjustability with precise tensioning and retensioning under direct visualization for any labral repair or simplified knotless remplissage technique.
The knotless 1.8 fiber tack system offers a comprehensive portfolio of instrumentation, such as curved, straight, and slotted guides to provide versatility to facilitate optimal anchor placement.
In complicated cases of glenoid bone loss, the new Arthrex Bone Block Cerclage system offers an arthroscopic technique that preserves the integrity of the subscapularis by utilizing fiber tape cerclage sutures to create a strong, metal-free construct.
Help your patients stay in the game. Learn more about Arthrex's minimally invasive shoulder innovations and techniques at arthrex.com and orthopedia.com. Today's episode is going to focus on 2 common athletic shoulder injuries that we see in American football: traumatic anterior shoulder dislocations and acromioclavicular joint injuries. We'll dive into the acute on-field management, followed by treatment thereafter, including nonoperative and surgical treatment options.
We are joined today by Dr. Kevin Farmer, a professor of orthopedic surgery at the University of Florida, a team physician for the University of Florida Gators, and the editor of In-Season Management of Football Injuries textbook. He is also a past president of the Florida Orthopaedic Society and the Florida Alliance for Sports Medicine, and a board member for AAOS and the Southern Orthopaedic Association.
So without further ado, let's get to the field house.
All right, Kevin, thank you for joining us today for a special episode of the Sports Docs podcast live at the exhibit hall at AOSSM in Denver. So welcome to the show.
Thank you. I'm excited to be here.
Awesome. So before we dive into a couple specific shoulder injuries and how you treat them, we want to first start with your initial evaluation and management of a player with a suspected shoulder trauma on the field. So you notice there's a player down on the field. Maybe you didn't see the play. They're just clutching their shoulder. What are you most concerned about, and what are you doing when you reach them on the field?
Yeah, I try to when you get there, try to get the story as to what happened. Mm-hmm. You know, just hey, what happened, what's going on. Try to hear from them. I want to kind of pinpoint where they're complaining about. Do a quick palpation, look for crepitance or step offs or anything obvious, like there'd be a sign of a fracture or something along those lines. Obviously, feel the shoulder, the lateral aspect of the shoulder, make sure there's no concavity or things that maybe make you think of a dislocation or something along those lines. If you can do a quick little neurovascular check, make sure things are moving, those kind of things. If you can get to a video monitor, a lot of us have now video monitors on the sidelines. Yeah. And so a lot of times I'll say, can you pull that up before I go out there? That way I can get back and see exactly what happened, because a lot of times you get out there and they're kind of writhing around screaming and they don't know what happened. Yeah. So it is nice to have that ability to look back and see what exactly occurred, and they give you a better idea of what may be going on.
Yeah, I think that is a big advantage that has come about. As far as we know from the NFL Combine data, some of the more common injuries that happen in football, so AC joint injuries, shoulder instability, as well as burners. So we're just going to really focus on those top 2. But first off, starting with shoulder instability. So your initial exam, for a traumatic dislocation, is obviously done on the field, and then, maybe you're seeing them in the locker room or in the tent. But as far as if you suspect that it is dislocated, are you trying to reduce right away? Do you go in the tent? Do you go in the locker room? Do you inject? Get an X-ray first? What's your sort of method in that setting?
Yeah, ideally, if you can pinpoint it right away and have an idea that's what's going on, and kind of try to pull a reduction before they get idea, they figure out what's going on. Yeah. I think that's helpful because their muscles aren't as tight and they're not guarding and resisting. So I've had several that have dislocated, right in front of me on the sidelines, that I go there and I palpate and I feel that it's dislocated. Before they even knew what's going on, I've already kind of popped it back in. That's
Yeah.
the ideal
Yeah.
situation, but that doesn't always happen. And so if you get to them a little bit later and they're already kind of starting to guard, we'll go to the tent. The problem with the tent is the training tables are high. They're fairly high up, so you can't get the leverage that you can get on someone who's down on the ground. So I find it difficult to reduce the shoulder in the tent. So in that case, if you can't get it on the field, we'll often go back to the locker room, have a little more space and a little quieter environment. And again, doing it with better leverage, and these kind of big muscular guys can be very helpful.
Yeah.
And then if I can't get it, then the injections are always kind of the next step along the way. But kind of the order of importance, if you can get it right away, I think that's the best. And then make sure you have the setup to do it, leverage, help, assistance, all those things. And then if you can't get it that done that way, then go back in the back, take your time, kind of get what you need to do it.
Yeah, absolutely.
Absolutely. So we've gotten them successfully reduced, maybe on the field. They're obviously going to go for an MRI to take a look. So how are you counseling this athlete on non-surgical versus surgical treatment? Does it have to do with first time versus recurrent, MRI findings, in season, out of season? Like, how are you kind of counseling them? Because most patients will listen to us. So
Yeah.
what are you advising?
Yeah, this exact question of the last 15 years has kind of led me to look at data behind in-season versus out-of-season management. I didn't write a book, but I edited a book just on that issue, where they look at different, all the different injuries. What's the data that we have? And there's not a lot of data. So I think you do have to understand the pros and the cons, the risks. What's the benefit of an athlete getting back, this season versus wait until next season? What's the risk of getting back? And so I think having all that information and really letting them make an informed decision. If they're a junior and this season really matters for them getting drafted, then they're probably willing to take more of a chance. If they're a freshman and they've got 2 or 3 years left, and then maybe they want to get something done now and not take the chance of having things worsen if it happens again. But I think we have to be honest with the data that we have, and let them and their parents and the coaches, and now you have advisors and agents, they're all involved, and so they have to be able to make an informed decision on what's in the athlete's best interest. And I think it's our job to give them the information to let them make that decision.
Yeah, for sure. And, say in the example where you do have an athlete, it's the beginning of the season, and, say quarterback, non-dominant shoulder, and they decide, let's try and do this non-operatively. Like, what do you do? What does your non-operative protocol look like for those guys?
Yeah, certainly want to get their range of motion back. Want to work on a rehab plan, get their strength back. There's some good studies out there that links. The simple shoulder test is a good study to give you an idea of how long it may. It's inversely proportionate to the simple shoulder test. So if you can get those numbers, you can get an idea how long it may take them to get back. So at least gives you some kind of generalized time that it may take. But once you can get the range of motion, their strength, if they're in a position that you can put a harness on, I do like harnesses in football, the ones that attach to the pads. If they're a running back or a skill player, they can't use a harness because the ball doesn't sit well. So then to sully in that population is a better option. But once you can get their strength, their motion, they can protect themselves, and you feel confident that there's not any major path, there's no big bony bank card or anything that's going to put them at higher risk, then I'm comfortable kind of letting the athletic trainers work them back in with the progression and see how they do.
Yeah, and I think, that sort of leads to like trying to figure out, what, obviously you're working as, with the athletic trainers on this, but determining that, okay, you're now ready to go back to play. Is there anything else that you rely on?
We have the on-field data where they can do catapult data. So we have some baseline information about kind of how active they were typically, and so if they're doing some practice, return to practice, we can compare that to where they were. And if they're still limited, then they're guarding and not kind of where they need to be. So that data can be helpful.
Yeah.
We have some biomechanical evaluations that we can do. That's with I'm blanking on the one that we have the. I can't remember the term, where they can do the 3D kind of emotion analysis.
Sure. Yeah.
We have that on campus, and so we can get some ideas of their movement patterns and things and compare that to baseline. And that will give you some assistance. But really, the athletic trainers are kind of the captains of the ship at that point. Once you've kind of realized, hey, the risk is this is the risk. We've explained the risk to them. I'm comfortable where they are. Then I leave it to them to kind of, because they know the athlete a lot better than we do on a day-to-day basis. Where are they? And let you progress them kind of until you think you're comfortable with them getting back out there.
Yeah, makes sense.
Absolutely. So now we want to discuss surgical treatment. So let's make it an easy case. So recurrent instability, large Bankart tear, and end of the season. So
Yep.
he's agreeable to go with
Yep.
surgery. You don't have to fight him or his
Yep.
parents too hard. So can you walk us through your surgical technique in terms of positioning during
Yep.
the surgery, what implants you may use, kind of tips and tricks to make it go smoothly?
Yeah, so I'm lateral for all my shoulder arthroscopy. In a primary Bankart, to me, it's going to be a arthroscopic Bankart. I don't jump to Latarjet or anything like that. If you've got bone loss, that's a different discussion. But a primary anterior labral tear for me is going to be arthroscopic Bankart. I've evolved into a much more aggressive approach to fixation. So I believe in the circle theory that we've had where, that most of the tears are anterior, but it's not a true unidirectional kind of an issue. It's just, and you guys have seen most cases kind of comes on the back, and so I almost always have at least 4 anchors in the front, and usually 2 anchors in the back. So I think you have to retension the hammock in both directions, and not just the anterior direction. I like the knotless fiber tack anchors. As it allows me to kind of get a combination of simple mattress, and kind of migrate that, starting from inferiorly to superiorly. I change the amount of shift based on the position that they play. So if it's a thrower or quarterback, then I'm not going to shift it as much. I'm going to try to get it back to where it anatomically needs to be. But if it's an offensive lineman or someone that I'm not worried about their freedom of motion, I'm going to maximize the shift as much as possible.
Keep them stable.
To get them more stable. And then you got to robbing Peter. I tell them all, you're robbing Peter to pay Paul. We're going to make you a little tight, but that's why we're doing this operation.
Absolutely.
Yeah, and I think, we hadn't thought about it touching on this topic, but it's just sort of coming to my mind. Like, we always think about this with the superior labrum tears where, based on the age, what is their activity and stuff, are we making them too tight such that, they don't love to do overhead? So do you also sort of think about that if it sort of extends a little bit more superiorly? How do you deal with that position-based?
Yeah, same thing. I mean, in an overhead athlete or a receiver or a safety who needs to have that motion high up, then you got to be a little careful, especially as you get to that sublabral foramen. Now, you don't want to incorporate that into your repair. So that's kind of the art of instability surgery, is that it really is, it's not a cookie cutter operation. You've got to adjust it based on the athlete, based on the pathology, based on what their position, based on their desires. All those things go into account when you make your decision. I almost always include a rim plissage in a contact athlete, even with a minimal Hill sacks. I think the data clearly shows that it reduces recurrence rates if you can add that. I think it blocks the defect, but I think probably more importantly, it tethers to the posterior capsule. So now you got to have more energy to dislocate, and so I think that's a very valuable. But the same thing, I wouldn't do that with every overhead athlete that has it too. So you got to adjust that based on patient factors and athlete factors.
Yeah, actually, can we dive into that a little bit as far as the details? Like, and how do you see sort of that algorithm with rim plissage? Because it's similar to like the ACL and the LET. Sometimes we're like, does everybody need this?
Right.
And we can sort of swing too far in a direction, but we're getting there with instability where we're looking, more people probably need it than we thought in the past. But how do you work through that?
Yeah, I mean, I think that recent level 1 paper that showed the recurrence rates greatly decreased by the addition of a rim plissage, I think really was an eye-opening thing. And I kind of believed in that, but didn't have the data to support it. It made sense to me, and so I was starting to do more and more. But once that came out, I said, this does make sense. So I think in a high-risk athlete, any contact athlete, I'm probably at least 95% are getting rim plissage. And most of them have a small defect, but even in a small defect, I do think it plays a role. It's the overhead athlete. I had an Olympic level swimmer who dislocated their shoulder, had a Hill sacks, and that athlete, do they need it necessarily? I decided not to do it in that one just because I worried about a little bit of motion loss. So again, every athlete, you got to take those things into account, because in an overhead athlete, if you over tighten them, like you said, that may adversely affect their ability to get back. And so you want to make them stable, but you also want to let them get back to the stuff that they want to do.
And the techniques involved, has been evolving over time too, where, there's the percutaneous, there's, people doing it in all different ways. How has that evolved for you?
Yeah, so I used to use like a corkscrew, just a basic anchor, and then, come through with a bird beak and then tie over the top. And it was fairly tedious. Now I've gone to the percutaneous 2-6 fiber tacks, and then using the bridge technique where you use across, and that to me has been very, very successful. And if I have any question about bone or anything, then I use the knotless corkscrew. Does the same thing.
Okay.
So it's a little bit different. So I have both of those options available. And Nautilus corkscrew comes with a nice percutaneous kit, which makes it real easy to just come through superiorly, come through inferiorly, and then pass them around. So I use those kind of anchors interchange. Most younger athletes get the fiber tack, and if they're a little bit older or any question, then I like the Nautilus corkscrew.
Makes sense.
So a couple questions about the remplissage. So, one of, I think it was Albert Lynn's paper looked at in the setting of what they called like subcritical bone loss, that you can add a remplissage and reduce the risk, but you take care of contact athletes where I feel like a lot of times people are like, just go for the latter J, right? So how are you deciding how much bone loss is too much bone loss in terms of adding a remplissage to maybe allow that person to undergo a formal band guard repair rather than a latter J? And at what point would it push you towards considering a primary latter J?
Yeah, I don't know that I've done primary latter J on any of my contact athletes in the last 10 years. All the ones that I've done have been ones of either massive bone loss, like a seizure patient, or someone where it's just this is not going to work, or they've failed a previous bank card.
Well, that's so good to hear because I feel like sometimes at these meetings you hear like, oh, everyone should be having a latter J because it reduces the risk. I mean, sure, it'll keep the shoulder more stable, but at what cost? So it is actually very nice to hear you saying that, Catherine.
Well, I was going to say it was interesting. We had Mark Price on. This was, 2 years ago or so, and he's working with the Patriots, but then he would also work with I almost said the Avs because I'm Denver, Bruins, and he was talk about how with NHL, a lot of them wanted the latter J, and it was like because they were like, it was almost like, well, that guy had it, so I want it, and it almost, it wasn't even so much, it was like driven more by the athlete because they just saw other guys got it, and that's what felt right for them.
Yeah.
So
versus NFL, it was the exact opposite. Like no one wanted a latter J, they all wanted a bank card. So.
And that may be just the European influence. A lot of the NHL are from Europe, and they've seen that as being more accepted. Whereas, as you guys know, from our data, that we tend to favor more of the bank guards. And if you look at the combine data, that latter J hardware complications were 30% on the athletes that came in. So, I mean, even though it's a successful operation, there are downsides, and I think you got to weigh those pros and cons when you make your decision.
Absolutely.
Yeah, great point.
Today's episode is proudly supported by Nice Recovery Systems and the Recovery Shop. Nice Recovery, renowned for its leading iceless cold compression machine, has partnered with the Recovery Shop, a premier platform for postoperative products. This collaboration ensures unparalleled patient service and access to the flagship Nice Recovery machine.
Elevate your recovery experience with the finest support and innovation at shop-recovery.net. For the Nice Recovery machine, you can see more about that unit and the innovation going on here, right in our backyard in Boulder, Colorado, at www.nicerecovery.com.
So now we're going to shift to another common shoulder injury in American football, and that is acromioclavicular joint injuries or AC joint injuries. So for our listeners, we did an injury report episode on this back in the fall. We do these NFL injury report episodes where someone goes down. I believe it was Derek Carr went down with an AC joint injury. We talk a little bit about it. So for our listeners, that's episode 56 if you want to check it out. So you can check it out too, Kevin. So you examine the player at the start. Their shoulder is not dislocated, and your evaluation is more concerning for an AC joint injury. So what's your next steps in terms of imaging in order to guide your counseling of that patient in terms of return to play or need for surgical treatment?
Yeah, well, I mean, first on field, if you're making decisions on return to play same day, you're going to really get a good feel for any crepitance or any major step off. If it feels, like a grade 1 on exam where it's not elevated, just painful, and I don't know that I necessarily have to get an X-ray right then, but if you can get an X-ray or even we have ultrasound available just to confirm there's not a fracture or something like that, then I'm comfortable doing a local anesthetic injection and trying to get them back. And the data, we have good data in the rugby literature with that long 5, 15, 20-year data showing no downside to doing that. And so I have no really concerns about that. But if they're more tender, if you feel a major step off, if you bring them across and it spits out the back in the trap, or if you happen to resisted external rotation and it spits out posteriorly, then that's a more unstable, kind of that type 3B model, idea where you have a little elevation, but it's anteriorly, posteriorly unstable. I think you want to identify those and separate. Obviously, the type 5s are a different animal. With the 3Bs and the 3, I think that's a very important kind of differentiation. But, in most case of contact athletes are going to get back to play without surgery in most cases. And so if I can get a cortisone shot same day as in practice, if they can get it before the inflammatory process sets in, I think that saves up to a week of time. We'll do an ACP injection in the training room that right away to kind of mitigate the the inflammatory response. I think those things can be helpful.
Yeah.
Yeah.
I'm going to take a drink real fast.
Yeah, go for it. Yeah, they actually. Have you seen Netflix? They just put out Receivers. Have you
I
seen
saw
this?
it out
to
there. I
every
haven't seen it yet.
physician.
But they cover this. It goes into detail. I'll let you guys
Oh,
see
really?
the
Oh,
episode or
nice.
whatever. But
Interesting.
it's interesting. There's like a, an on-field AC injury, and
Yeah,
you go
yeah.
in the locker room, you see the injection. It's like very dramatic. So
Yeah, and so I think in the contact depth, you got to be careful. I think we've done it. There's been an evolution away from, larger tunnels and things like that.
Yeah.
And so trying to migrate more to smaller tunnels and arthroscopic approaches. So I do all my reconstructions arthroscopic assisted. I add a graft for every case. But in the contact athlete, I tend to lean more into the non-surgical
Yeah.
approach because the risk of fractures and things like that, you want to make sure that, what you're doing, you don't have an issue from that. And
Yeah.
so, I always heard, a famous story that I heard from John Reeves, my fellowship mentor. He took care of Dan Marino back with the Dolphins, and he had a type 5 in his throwing shoulder in college,
didn't know
never
that.
got it fixed, and had a pretty good career. So,
Yeah,
I always
pretty good.
kind of, I've kind of taken a step back
Adequate.
and kind of use that as a guide that, hey, maybe not all of these need to be fixed, but
Yeah.
the ones that you decide you do need to fix, I think we've got much better options now than we used to have.
true.
Absolutely.
Yeah, and I do think, the majority of them, and we see that with the combine data too, it's all, non-operative. So it sounds like, your non-operative approach, you're trying to shut down that inflammatory process really quickly, but they're obviously starting with the athletic trainers right
Yes.
away. And then I would assume similarly your return to play testing. I think we're talking about in a session yesterday with all the catapult data. Sometimes you're like, there's so much data, we don't
Yeah.
even know what to do with it. But I like, your suggestion where you're just kind of almost looking broadly at their activity
Yeah.
levels, and that really it's telling.
Yeah.
Even if there's not a specific metric per se, it's
Yeah.
like if they're not at that same activity, there's something that either mentally or physically is holding them back.
And I think having a collaboration with the athletic trainer and the strength and conditioning staff, because we have one of our strength conditioning coaches is kind of our catapult person,
Yeah.
and so they can look at the data from their end too. But even just getting a percentage,
Right.
they're 60% as active as they usually typically
Yeah.
are. There's something that's limiting them what they're doing. Now, whether or not they'll tell you what that is,
Yeah.
that's a different story. But there's something that's keeping them from doing what they typically do,
Yeah.
and that usually is a sign that they're still kind of protected with protecting
Right.
things or not 100% at that point.
Yeah, I like that.
Yeah. So I do want to, I know majority of these are going to be treated non-surgically,
Yeah.
but just for, for an example, say
Sure.
this patient doesn't like the deformity, it's end of
Yep.
season, they want it surgically addressed, they have a type 5. If you can get to them acutely, you mentioned always having a graft.
Yep.
Are you doing like an arthroscopic system, like a tightrope plus a
Yep.
graft? Are you always adding a graft? Kind of how are you deciding how you surgically approach that?
I always had a graft.
Always had a
and
graft, okay.
my evolution in AC is just like probably many of ours has changed over the years.
Seriously,
Yeah.
yeah.
Just based on certain patients or things that stick out in your mind. So
Yeah.
I always had a graft. I do think having biology. I don't think that all of these CC ligaments heal every
Yeah.
time. Even with great initial fixation, I think the biology is still limited. So I always had a graft. I do like a tightrope or a dog bone for the initial fixation. I do them arthroscopically assist. I don't drill through the coracoid, so I wrap
Yeah.
fiber tapes around the coracoid. I wrap the graft around the coracoid, all arthroscopic. And then if it's a contact athlete, then I'd put a single 2-4 tunnel in the clavicle for the dog bone, and then I would wrap graft around. So you only
Okay.
have 1-2-4 tunnel in
Yeah.
that setting, and so you have no coracoid tunnel, and a 2-4 clavicle. So I think you've got to a point where you've really minimized the risk in that setting, but you've maximized the strength because you have this great kind of fixation, and now
Yeah.
you have biology on top of it.
And are you doing autograft? Or
No,
you take
allograft, yeah,
Allograft. Yeah.
Yeah.
And that's sort of what I feel like. There was a period of time where people were using more like hamstring auto, but
Yeah.
I think that's sort of
Yeah.
there's a downside to that.
Yeah.
Yeah,
Especially in your population.
yeah, sure.
Well, it's very
Yeah.
interesting to hear the wrapping around the coracoid because
Yeah.
I usually just drill through
Yeah.
and through to
Yeah.
do the dog bone, but I actually have a revision coming up, and he's got
Yeah.
lots of holes in his clavicle
Yeah.
and
Yeah.
in his coracoid that has failed. They had a suspensory device
Yeah.
in there, and so I thinking about how can I avoid re-drilling. That's very
Yeah.
interesting. You can loop around and then just use
you
one
can
of
loop
those.
around both the coracoid and the clavicle
Yeah.
and not drill through anything. If you
Yeah.
wanted to, you've got the fixation, the strength
Yeah.
to do that.
I did that once actually it was an elderly gentleman, but skin threatening, and
Yeah.
I did the fiber tape cerclage
Yeah.
around
Yes,
the
it's
collarbone
another thing you
and
do, yeah.
around the coracoid, and then tensioned it,
Yeah.
and that plus a graft looped around as
Yeah.
well too. It made me sleep better at
Yeah,
night, not
sure.
worrying he was going to have a fracture.
yeah.
Yeah. Absolutely.
Yeah, no, those are great points. Is there any indication where you would open?
I have not opened probably in 8 years. Knock on wood. Part of it's just because the coracoid passage is much easier arthroscopic.
Yeah.
And I work with residents and fellows, and I'm trying to look down into a hole, and they're trying to pass. And I couldn't handle the stress anymore. So now I can go in there and see it, now know where I am, and pass everything. So for me, it's much easier to find that subcoracoid space. I know where the plexus is, then I can do things. So I have not, knock on wood, have to open them. But it certainly is a tried and true approach, and nothing wrong with that.
For sure.
Absolutely.
Yeah.
Awesome. And then we do want to quickly just talk about rehab of these AC joint injuries. So if you treat them surgically, are you starting PT pretty immediately? Do you do 6 weeks just locked up, supporting the weight of the arm? Kind of how do you protect
Slower
them?
the better.
Slower
Because there's a high percentage, I call high percentage of knuckleheads in this population that aren't going to listen to you. And so I want to be as slow as I can, because like you said, the weight of what's happening is the shoulder girdle is what's pulling down. It's not the clavicle going up, it's the other way around. So you got to give that a chance to heal before you put that stress on the repair, on the reconstruction. And so I usually, we're sling for 6 weeks. I may start 4 weeks, start doing some pendulum Codmans, those kind of things, but really the slower the better, because you just want to give us a chance to heal. And like I said, a lot of the ones we see are kids that don't go to rehab very consistently, or that it was a trauma or a motorcycle or something where it's just a population that can be very, very difficult, and you want to make sure that you maximize your outcomes. And in most cases, that's, hey, just take time to get it easy. Get it to heal.
Yeah.
Absolutely.
No, that's great.
Awesome.
Yeah.
Well, thank you so much for joining us
Yeah,
here today.
it's
This was an
amazing.
awesome discussion, and I think it went really well. And thank you for taking the time. We know you're very busy. So
No, I appreciate it. Thank you. You guys doing a great job. Thanks for
Yeah,
having
and
me.
congratulations on you have just the most amazing career. So
Yes.
Thank you very much.
That's
I
awesome.
appreciate that. Thank you.
Yeah.
Awesome.
All right.
Yeah,
Take
thank
care.
you.
Thank you.
Thank you for listening to this episode of the Sports Docs Podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love hearing from you.